Imagine for a second that you are recovering from a stroke.
Right, which is a monumental victory just on its own.
Exactly. You've survived the initial neurological earthquake in your brain. You're exhausted. Your family is terrified but relieved. And you're finally starting this, long, arduous process of physical rehabilitation.
Yeah, it's a huge mountain to climb.
It really is. But then almost immediately, you run into a completely new mechanical nightmare that basically has absolutely nothing to do with your brain.
Oh, it is such an agonizing secondary complication for these patients.
Right, because your affected arm, having lost its muscle tone, it just hangs there, entirely dead and heavy at your side. And day by day, hour by hour, the simple, relentless force of gravity is, well, it's literally pulling your shoulder joint apart.
Yeah, under the sheer weight of your own limb. You're already in the fight of your life trying to rewire your neural pathways, and suddenly your actual skeletal structure is failing you.
Just because you're sitting up in a chair.
Exactly. The physical architecture of your shoulder just simply gives up.
So it's a condition known as shoulder subluxation, right? And it is a massive roadblock for stroke survivors.
A huge one, yeah.
So our mission for this deep dive is to explore whether we can essentially hack the body's electrical system to stop this from happening. We're diving into a landmark 2017 meta-analysis published in the journal Clinical Rehabilitation.
And I have to say, this is a seriously robust piece of scientific synthesis.
Oh, absolutely. The source material here is incredible.
It really is. It was spearheaded by Jae-Young Lee from Wonkwang Health Science University over in Korea. And they collaborated with just an absolute powerhouse team from the University of Southern California, Lucinda L. Baker, Robert E. Johnson, and Julie K. Tilson.
USC has, one of the top physical therapy programs in the world, right?
Oh, top ranked globally. When a team like this pulls data together, I mean, the entire neuro rehab community pays very close attention.
For sure. So they were investigating a technology called neuromuscular electrical stimulation, or NMES.
Right, MAS.
And they essentially wanted to know if strapping electrodes to a drooping shoulder and actively shocking those paralyzed muscles back to life could halt or even reverse this joint separation.
Which sounds like science fiction, but is very real.
It is. And whether you are a physical therapist, a caregiver, or just someone fascinated by the resilience of the human body, understanding this very specific closing window of healing could drastically alter a stroke survivor's trajectory. Okay, let's unpack this.
Let's do it.
Before we get into the electric shocks and the clinical data, we have to understand the physical reality of a failing shoulder.
Right, because the human shoulder, specifically the glenohumeral joint, it's a true marvel of evolutionary mobility.
I mean, you can pitch a baseball, reach behind your back, do a butterfly screw.
Exactly. But that extreme mobility comes at a really heavy cost to stability.
How so?
But unlike your hip joint, which sits securely in a deep bony socket, your shoulder is basically a golf ball resting on a very small flat tee.
Oh, wow. That sounds precarious.
It is. It relies almost entirely on the surrounding muscles, the ligaments, and the joint capsule to actively hold that heavy humeral head, the ball at the top of your arm, securely against the socket.
And after a stroke, during what clinicians call the flaccid stage, those active supporting structures just go totally offline.
Completely slack, yes.
The hypotonic muscles, the ones that are supposed to be constantly firing with a low hum of background energy just to keep the joint tight, they lose all their tone. To give you a mental image, imagine hanging a heavy, soaking wet winter coat on a flimsy wire hanger.
Oh, that's a perfect analogy.
Right. Without a strong, solid hook to hold it up, the thin wire just starts to warp and bend under the continuous downward pull of gravity.
And that heavy, wet coat is the paralyzed arm.
Exactly. And the warping wire hanger is your shoulder capsule.
What's fascinating here is how a purely neurological event, a disruption of blood flow inside the skull, translates directly into this devastating structural mechanical breakdown inches away in the shoulder.
Because gravity just takes over.
Right. It pulls the arm in an inferior or downward direction. And this creates a vicious cycle.
Because once that golf ball starts slipping off the tee, I mean, it's not just an aesthetic issue. It actually derails your entire recovery.
Severely. It impedes upper extremity functional recovery. If the joint isn't physically seated in the socket, you literally cannot participate safely in arm therapy.
But perhaps more terrifying is the pain, right? This drooping drastically increases the risk for something called complex reader's pain syndrome.
Or CRPS, yeah.
I've seen CRPS mentioned in the literature, but I've got to ask, Why does a drooping shoulder cause such intense pain? Is it just the bone tearing the muscle?
It is actually much more sinister than that. When that joint drops, it physically stretches and compresses a dense network of nerves and blood vessels running through the armpit and shoulder.
Oh, geez.
Yeah, so your nervous system basically hits the panic button. It starts misfiring, interpreting completely normal sensations as agonizing pain. It causes severe swelling and even changes the skin temperature.
Wait, it changes the actual temperature of the skin?
It does. Add to that the complex soft tissue injuries, like the ligaments and the joint capsule becoming physically overstretched. And if you leave it untreated for too long, those tissues permanently lose their elasticity.
Meaning the separation just becomes uncorrectable.
Exactly. It's permanent.
Man. So if gravity is doing all this damage 24 hours a day, a physical therapist manually pushing the arm up for, what, an hour, 3 times a week? That just isn't going to cut it.
Not at all. It's a drop in the bucket.
So how do you fight gravity when the patient goes home and sits on the couch? And I guess that logical gap brings us right to the intervention these researchers analyzed, NMES.
Yes, since the brain's natural command center is temporarily offline and isn't sending the signal to contract those muscles, NMES essentially bypasses the brain entirely.
So how does it actually work in practice?
Clinicians use sticky surface electrodes, placing them directly on the skin over specific superficial nerve and muscle groups. Then a small device transmits controlled electrical impulses that artificially force the muscle fibers to fire and contract.
And they aren't just slapping pads on the shoulder at random, right? I was reading that the therapy is incredibly targeted.
Highly targeted, yes.
They specifically aim for the posterior deltoid and the, let me make sure I pronounce this correctly, the supraspinatus muscle.
You nailed it. Supraspinatus.
Thank you. So if you reach over and feel the very top and the back of your own shoulder right now, that's the real estate we were talking about.
Right. Those specific muscles act as the biological counterweights to gravity.
They are the exact vertical cables responsible for lifting and stabilizing that heavy arm bone.
Exactly. And the meta-analysis from the Korea and USC team was incredibly rigorous in evaluating the specific targeted therapy.
Yeah, they didn't just highlight one small optimistic trial.
No, they synthesized 11 high-quality randomized controlled trials. Together, these studies looked at 432 stroke patients.
Which is a really solid sample size for this kind of study.
Absolutely. They split them down the middle. Half received this electrical stimulation in addition to their conventional therapy, things like arm slings, careful positioning, standard manual therapy.
And the other half?
The other half received only the conventional therapy.
Okay, and the researchers used something called the Pedro scale to measure the quality of these 11 trials. Think of the Pedro scale as like a Michelin star rating system for physical therapy research.
That's a great way to put it.
It checks if the study was blind, if the randomization was fair, if the data reporting was complete. 7 of the 11 studies scored good, which means the methodologies were rock solid. We aren't looking at fuzzy math here.
No, it's very sound science.
But I have a fundamental question about the electricity itself. When we zap these muscles, are we just forcefully twitching the meat to keep it from atrophying? Or is the electricity actually teaching the damaged brain something new?
That is the million-dollar question. In the acute phase right after a stroke, it is actually doing both simultaneously, which is why it is such a powerful tool.
Okay, explain that.
Well, first, it provides immediate mechanical support. By forcing the posterior deltoid and supraspinatus to contract, the electricity literally pulls the joint back up into the socket.
So it's acting as an internal sling.
Precisely. An internal biological sling. It takes the sheer physical tension off those delicate ligaments so they don't permanently stretch out.
But what about the brain side of the equation?
Neurologically, the stimulation creates a massive sensory feedback loop. When the device forces the muscle to contract, sensory receptors inside the muscle and joint wake up.
Ah, yeah.
They send loud, urgent signals up the spinal cord to the central nervous system saying, hey, movement is happening down here, pay attention.
That makes total sense.
Right. And this ascending sensory drive is critical for neuroplasticity. It forces the damaged brain to acknowledge the paralyzed arm, potentially facilitating the brain's ability to rewire surrounding healthy tissue and regain voluntary control over those muscles.
Here's where it gets really interesting, though, because you'd naturally think, hey, we have this incredible digital tool that acts as an internal sling and talks to the brain. Let's prescribe it to every stroke survivor on Earth forever.
That would be the logical assumption, yes.
But the data reveals an incredibly sharp dividing line.
Yeah.
I mean, there is a literal cliff in the effectiveness of this treatment, and it is based entirely on the calendar.
Yeah, the time elapsed since the stroke occurred is the single biggest variable in this entire body of research.
It's crazy.
It really is. The data forced the researchers to divide the patients into two distinct camps. The acute or subacute patients, meaning those who are less than 6 months post-stroke, and the chronic patients, meaning those who are more than 6 months out.
And the results for that early group, the acute patients, they are just staggering. The electrical stimulation provided a large, highly significant reduction in shoulder subluxation.
Very significant.
Statisticians measure this using a metric called a standardized mean difference, or SMD. Basically, in the world of clinical stats, an SMD of 0.8 is considered a very large, undeniable effect size.
Right. 0.8 is the threshold.
But for the acute stroke group, the NMES treatment hit an SMD of negative 1.11. It was a massive home run. The electricity actively pulled the shoulder back together and kept it there.
It did. But then you turn the page and look at the chronic patients, the people who were, on average in these studies, about 9 months post-stroke.
Right.
For them, the results just fell right off the cliff. There was absolutely no clear benefit. The reduction in joint separation was statistically insignificant.
Which is wild. Why does the magic suddenly stop working? Does the body just build up like a tolerance to the electricity after 6 months?
Actually, it has nothing to do with electrical tolerance and everything to do with the biological realities of those two different recovery windows.
Okay, lay it out for me.
In the first few months, the acute phase, which averaged about 1 to 2 months in these specific trials, the survivor's body is in a state of rapid, spontaneous neurologic recovery.
The brain is actively trying to fix itself.
Exactly. The central nervous system is highly plastic, actively trying to heal and reroute damaged pathways. NMES essentially piggybacks on this intense natural recovery window.
So it's holding the joint physically secure while flooding the brain with that sensory input we talked about.
Yes, but past that 6-month mark,
Yeah, what happens then?
by the time a patient reaches 9 months post-stroke, two very unfortunate things have likely happened. First, that rapid, spontaneous motor recovery phase has largely plateaued.
The rewiring has slowed down.
Drastically.
Yeah.
And second, and practically more devastating for the shoulder, the passive physical structures, the ligaments and the collagen in the joint capsule have been hanging slack under the weight of gravity for the better part of a year.
Going back to our analogy, the wire hanger is completely, permanently warped.
Yes.
Exactly. For the chronic patients, putting the pads on and turning up the current will absolutely cause the muscle to contract. The electricity still works.
It'll pull the shoulder up while the machine is buzzing.
Right, while it's actively buzzing. But the moment the therapy session ends and the machine clicks off, there is no restored background muscle tone, and there is no tight ligament structure left to hold it there.
The shoulder just drops right back out of the socket.
It drops right out. Wow. The window of opportunity is incredibly unforgiving. That really drives home how urgent early intervention is. If your parent or spouse just had a stroke, you have a ticking clock.
You really do.
But assuming you are within that magical acute window, under 6 months, how much electricity are we talking about? If I have a bad knee, I might wear a physical brace for 16 hours a day. If this is acting as a digital brace, why aren't we just strapping a battery pack to their belt and leaving the electrodes turned on from breakfast until bedtime?
That's a great question. And the researchers actually look very closely at dosage. They compared short sessions, which they defined as 1 hour or less per day, against long sessions, which were anything more than an hour a day.
And what did they find?
Clinically, both durations worked beautifully for acute patients.
But the longer sessions must have driven better results, right? I mean, more time holding the joint up equals better outcomes.
Statistically, yes. Short daily use yielded an impressive SMD of negative 0.91, but longer use gave an even stronger SMD of negative 1.49.
Then I go back to my question, if longer is statistically superior, why not leave the pads on all day?
Because human skin was not designed to be an electrical conduit.
Ah, good point.
In the real world of clinical rehab, you constantly have to balance maximum efficacy with patient tolerance. Passing electrical current through the skin for hours on end causes severe adverse effects.
Like what?
We were talking about severe erythema, which is intense redness and inflammation contact dermatitis, and even minor electrical burns.
Ouch. But I would imagine modern medical devices have safeguards against burning people.
They do, thankfully. Modern NMES equipment uses something called asymmetric biphasic waveforms.
Sounds complicated.
It just means that rather than sending a harsh one-way current that builds up heat under a single pad, The machine alternates the current, passing it back and forth very quickly.
Oh, like shifting your weight from one foot to the other so neither foot gets too tired.
Exactly. That's a great way to think of it. This makes actual burns very rare compared to machines from 20 years ago. But if the patient is sweating, or if the sticky pad starts to peel up and the contact becomes uneven, skin irritation happens quickly.
And we have to remember the patient profile here, right? A stroke survivor might have dense hemiplegia.
Yes. For our listeners, dense hemiplegia means complete, dense paralysis and often profound sensory loss on one entire side of the body.
So they might not even feel that their skin is getting irritated or actively burned until it is far too late to stop it. Plus, practically speaking, asking a recovering patient to sit absolutely still with wires trailing off their arm for 4 hours a day, that's just a recipe for non-compliance.
Which is why, despite these slightly better statistical numbers for longer durations, the experts ultimately recommend a clinical sweet spot, 30 to 60 minutes of NMES a day.
Okay, 30 to 60 minutes.
Right. The ideal machine parameters are 10 to 36 pulses per second with a pulse duration of 200 to 250 microseconds done 3 to 7 days a week.
That's very specific.
It is, but that specific recipe is the optimal balance. It is long enough to get that strong therapeutic benefit, pulling the shoulder up and shouting at the brain, but short enough to avoid major skin breakdown and keep the patient actually willing to do the therapy.
Okay, so we've established that this technology is incredibly effective at physically putting the shoulder back into the socket if deployed early. But reading through the meta-analysis, there were two huge limitations to NMES that honestly stopped me in my tracks.
Oh, the limitations are crucial to understand.
First, applying this electrical stimulation to the shoulder did absolutely nothing to significantly improve overall arm motor function.
Yeah. It is a very common, very heartbreaking misconception among patients and families.
People logically assume that if we can just fix the shoulder, the hand will wake up and start working again.
Exactly. But it's like paying thousands of dollars to fix the cracked foundation of your house and then being shocked that it didn't magically repair the leaky plumbing in your upstairs bathroom.
Right. Yes, the foundation absolutely had to be fixed for the house to be stable, but the pipes are a completely separate, highly localized problem. Fixing the root structural issue at the shoulder doesn't automatically translate down the arm to fixing the hand.
That analogy perfectly captures the clinical reality. The outcome measures for arm function in these trials looked at the holistic use of the limb.
They weren't just looking at the shoulder joint itself.
Right. Simply stabilizing the proximal joint, the shoulder, does not magically restore the incredibly complex, intricate, fine motor control needed to grip a coffee cup or button a shirt.
So what do you do for the hand?
There are entirely separate, distinct NMES protocols that target the forearm and the tiny muscles of the hand for that specific purpose. Treating the shoulder prevents the shoulder from falling apart. It does not cure the arm.
Okay, structurally, I can wrap my head around that, but the second limitation is the one I aggressively push back on when reading the paper.
The pain findings.
Yes. The meta-analysis found no significant reduction in shoulder pain. How is that physically possible? If the joint is literally separating, tearing the capsule and crushing nerves, and this machine puts the bone firmly back where it belongs, shouldn't the pain drop immediately?
It seems completely counterintuitive, almost impossible. But if we connect this to the bigger picture of stroke neurology, the pain paradox starts to make horrifying sense.
Okay, walk me through it.
Remember, a stroke doesn't just knock out the motor cables that move muscles. It frequently causes profound damage to the sensory cables that feel the world.
So the brain's ability to even process what pain is has been totally scrambled.
Yes, patients with severe hemiplegia have massive chaotic sensory loss. Their central nervous system's ability to perceive, process, and accurately report pain is highly variable and often completely compromised.
So they might not feel a huge injury, but they might feel a tiny one.
Clinically, it is a known phenomenon that the physical magnitude of a shoulder subluxation simply does not correlate directly with the amount of pain the patient verbally reports.
Wow.
You can examine a patient with a massive multi-centimeter visible gap in their shoulder joint who reports a pain score of a 2 out of 10 simply because their sensory deficits are so dense they can't feel the tearing.
And on the flip side, you could have a patient with a tiny millimeter subluxation who is screaming in agony because of a very specific nerve impingement or severe muscle spasticity.
Precisely the reality on the ward. Because the baseline reporting of pain is so incredibly chaotic and unreliable across this specific patient population, the statistical data just turns into white noise.
It's all over the map.
Right. The study showed such wild, unpredictable variability in pain reporting that mathematically, there was no measurable improvement across the board.
That is so
The
wild.
clinical takeaway is very clear, though. Use NMES to prevent the mechanical, structural destruction of the shoulder, but do not rely on it as a primary pain management tool. It is a biological structural support, not a painkiller.
Wow. So what does this all mean for you, the listener? It means timing is everything in neurorehabilitation.
It truly is.
If you take away anything from this deep dive, let it be this. If you or a parent or a patient you are advocating for is in the early stages of stroke recovery, specifically under that critical 6-month mark, you need to ask a healthcare professional about
We
NMES.
can't wait on it.
Exactly. Adding just 30 to 60 minutes of daily electrical stimulation to the posterior deltoid and supraspinatus can safely, effectively manage shoulder subluxation and keep the architecture intact while the brain heals. It is practical, accessible hope backed by hundreds of hours of rigorously synthesized science.
It is a vital tool for that acute early window. But I just want to leave you with a thought about those patients left behind on the other side of the cliff.
The chronic patients.
Right. What happens to the chronic patients? The ones who are 2 years post-stroke, whose ligaments are stretched out, and who drop their shoulder the second the surface pads are peeled off.
Are they just out of luck?
Well, the sources we looked at briefly point toward a fascinating, somewhat futuristic solution currently in development: implanted microstimulators.
Wait, like inside the body?
Yes. Imagine a near future where, instead of dealing with sticky surface pads, skin irritation, and daily therapy sessions, a chronic patient undergoes a minimally invasive procedure. Tiny wires are implanted directly inside those specific shoulder muscles.
Oh, wow. That's incredible.
It acts as a permanent internal bionic support system. Whenever the patient stands up, the internal implant automatically fires, keeping the joint perfectly, effortlessly seated all day long without any external equipment.
That is mind-blowing.
It's not widely available in your local clinic just yet, but the technology is moving through development right now. It fundamentally changes the paradigm from a temporary therapy to a permanent bionic replacement. And honestly, it gives us an incredible glimpse into where the future of chronic stroke rehabilitation is heading.